Hello and welcome to another e-learning episode, this time as part of our rheumatology module, which was inspired from the EULAR campaign Don't Delay, Connect Today, and made possible by the patient group ARAM. With us today we have Dr. Michela Frendo, a rheumatologist and physician, who will be speaking to us about early referral of rheumatic and musculoskeletal disease. Why? Thank you, Dr. Frendo, for being with us.
Thank you, Gabriel, for the invite.
On to my very first question. Don't Delay, Connect Today. It's a very simple title. Can you describe what you mean?
Okay, so we will be talking about rheumatic and musculoskeletal disease. Just as a background, rheumatic and musculoskeletal diseases can be classified into the inflammatory and the non-inflammatory types. The common non-inflammatory rheumatic and musculoskeletal diseases consist of degenerative spine disease, osteoarthritis, osteoporosis, and fibromyalgia, and the common inflammatory rheumatic musculoskeletal diseases consist of crystal deposition disease such as gout, rheumatoid arthritis, spondyloarthropathies, connective tissue diseases, and polymyalgia rheumatica. Why are rheumatic and musculoskeletal diseases important? They are important mostly because of their prevalence. They affect a quarter of all people in the European Union, over 120 million people. Therefore, you can say that almost every family in Europe is affected by a rheumatic and musculoskeletal disease in some way. In the industrialized world, these diseases affect more individuals than any other disease group. They can affect both men and women and children. There are some rheumatic diseases which are more common to women, such as rheumatoid arthritis, fibromyalgia, systemic lupus, and scleroderma, and some are more common to men, such as gout and spondyloarthropathies. They also pose a big cost on the healthcare systems. Okay, they are a huge economic burden on global healthcare systems, where in Europe public spending totals to over 200 billion euros per year for rheumatic and musculoskeletal diseases. Therefore, they are the most expensive diseases for European health and socio-economic systems. The costs are not only related to diagnosis and treatment, but also to the drugs used and the care needed to care for these patients, the devices needed for these patients to use to function in their daily life, home modifications which are needed for these patients to function, plus the indirect costs related to these conditions, because these conditions are associated with the biggest cause of sick leave and premature retirement worldwide because of the pain and disability associated with the conditions. Also, although they are usually chronic and they don't cause sudden death, if left untreated, they may reduce life expectancy. Because of this, EULAR in 2017, EULAR being the European League Against Rheumatism, came up with the campaign Don't Delay, Connect Today in collaboration with patients group, healthcare professional associations and scientific committees to encourage early diagnosis of rheumatic and musculoskeletal diseases. Quick action upon presentation is vital, and patients should be assessed in a short period of time by a physician, preferably a rheumatologist, because there is scientific evidence to show that those patients who are treated early, particularly within the first 12 weeks of onset of symptoms, have a better outcome. There is less joint damage, improved long-term function, and there is an increased likelihood of achieving remission if patients are treated early. Where those patients in which diagnosis is delayed, there is a reduction in the quality of life and the physical ability of the patients.
So early referral is key, and now it's obviously important that if there are complex of symptoms, the early referral is made.
That's
how
right.
do patients typically present, and how is a diagnosis made in these circumstances?
Okay, patients usually can present with a wide variety of symptoms. The most common being joint inflammation, which is characterized by swelling, redness, erythema, and stiffness and decreased range of movement of the joint. If diagnosis is delayed, patients can even present with established deformity. because many inflammatory rheumatic diseases are multisystemic, other than joint pains, the patient can present with symptoms of internal organ involvement. Not very common, but one must keep in mind that patients can present with shortness of breath if the condition is a scleroderma, which is causing lung fibrosis, or rheumatoid arthritis itself can cause lung fibrosis. Other than symptoms of internal organ involvement, there is usually associated depression and anxiety because of the chronic pain which these patients are living with. So once the patient presents with the symptoms, I think the role of the clinician is an adequate history and physical examination before embarking on investigations if necessary. So I'll refer to some points in the history which are of relevance, such as which joints are involved and how long have the joint pains lasted, if there is associated swelling, stiffness, redness, decreased range of movement, together with other associated features such as rashes, which can be of significance in patients who suffer from psoriatic arthritis or lupus. Features of Raynaud's, which is classical, the triphasic color change, which you get in patients who suffer from connective tissue diseases, particularly systemic sclerosis and even in lupus. Also, a history needs to be taken regarding onset of symptoms, if there is a relation to previous upper respiratory tract or gastrointestinal infections, which would be suggestive of a reactive type of arthritis. And once an adequate history is taken, then one should proceed to perform a clinical examination, which I would say involves all the systems, not just the joints. So a pulse and blood pressure should be taken, and then particularly looking at the joints for which types of joints are involved, because that again can give you a hint to the diagnosis. For example, you've got involvement of the distal interphalangeal joints with bony swelling that is more in keeping with a degenerative form of osteoarthritis with the formation of Heberden's nodes, whereas involvement of the wrists and metacarpophalangeal joints and proximal interphalangeal joints would point more towards a persistent inflammatory symmetrical arthritis, possibly diagnosis of rheumatoid arthritis. One must not forget that these conditions can manifest with extra-articular manifestations also, such as the development of rheumatoid nodules in patients with rheumatoid arthritis, or the evidence of skin psoriasis for patients who suffer from psoriatic arthritis. So examination of the skin should be undertaken, the elbows, to look for tophi, for rheumatoid nodules, and then also general examination of the lung, abdomen, cardiovascular system, and the rough neurological examination should be undertaken. If then there is sufficient evidence that the patient may be suffering from a rheumatic condition, one might want to confirm this with further investigations, initially blood investigations. Inflammatory markers are very easy to order in general practice, and if there's suspicion of an inflammatory arthritis, it is expected that these will be elevated. What I must say at this point is that autoantibodies should be used judiciously and not be prescribed for any pain that the patient is feeling. I have some slides which I would like to share with you. So we can see the first slide is of a patient who suffers from crystal deposition formed by uric acid crystals in the first metatarsophalangeal joint. One can appreciate erythema and swelling that there is over that joint, gout being most common in the first MTP joint. However, it can affect all joints and can even present with a polyarticular pattern. At the bottom we can see tophi, okay, which are the uric acids conglomerate which have deposited in an index finger. That is also makes the diagnosis of tophaceous gout. This slide is a slide of a patient who suffers from rheumatoid arthritis. On the first picture on the top, we can appreciate the different stages of the disease. Whereas in the early stage, there is just a hint of swelling with no deformity. If the condition is let to progress, there is deformities which become established and permanent deformities which can then impair function. We can appreciate in the bottom slide rheumatoid nodules over the digits which are characteristic of seropositive rheumatoid arthritis, and also are more prominent in patients who are on methotrexate. This is a slide showing features of spondyloarthropathies. Spondyloarthropathies being a group of conditions which encompass a number of conditions, including ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. And this group of diseases has characteristic features in the sense of it can involve the sacroiliac joints, and there can be associated sacroiliitis. Patients can have dactylitis. We can see the second digit in the middle picture is swollen and red because of dactylitis. Entisopathy and enthesitis also is a manifestation of spondyloarthritis. In patients with psoriatic arthritis, we can see the bottom elbows, the bottom picture showing psoriasis over the elbows, and these all together are features of the spondyloarthropathies. A short note about systemic lupus. We can see the picture, the lady in the picture with the characteristic butterfly rash. And on the diagram which I have on the left-hand side of the screen, there are the manifestations of lupus, including possible manifestations of lupus, including serositis, oral ulcers, arthritis, photosensitive rash, blood dyscrasias, possible renal involvement, a malar rash, possible neurological involvement, and the presence of antinuclear antibody, which is positive in 95% of patients with SLE. This is a slide showing some features in systemic sclerosis, some features affecting the hands, including Raynaud's phenomenon, digital scars, calcinosis, calcium deposition can be a manifestation, and the swelling and puffy fingers, sclerodactyly, which is present in these patients.
And in fact, following this comprehensive overview of the clinical picture which the physician may encounter, may I take you back to the remark which you paused with regards to the use of autoantibodies.
That's right.
And you counseled their use to be judicious. We must be judicious in their use. I also understand that we frequently may take rheumatoid factor or antinuclear antibody. What do you comment about this practice?
Okay, I think that they can be very useful, but when used in the right clinical context. We must keep in mind that rheumatoid factor has a specificity and sensitivity for rheumatoid arthritis standing at about 65 to 70%, and it is by no way diagnostic alone. It is present in about 5 to 10% of the population, with some studies even quoting 25% in the older population. So you can imagine that if this is taken out of the clinical context, 1 in 4 patients with a positive rheumatoid factor of the older population would be referred to the rheumatology department uselessly, which will obviously overburden the system, lessening the time which is needed for patients who are more deserving. Other than being present in the normal population, rheumatoid factor can be present also in other rheumatological conditions. Not only rheumatoid arthritis, it can be present in Sjogren's syndrome, in systemic sclerosis, also in Still's disease. and also in non-rheumatic conditions such as in chronic infections, infective endocarditis, tuberculosis. So by no way is it specific for rheumatoid arthritis and can be more confusing if ordered in the wrong clinical context. Antinuclear antibodies, similar picture, present in about 5 to 15% of the general population, and should be used in the right clinical context so as to avoid useless referrals.
So we've gone through the workup in order to attain the diagnosis. Obviously, what treatment strategies are then employed for these patients?
Okay, on such a short discussion, it would be difficult to go through all the treatment strategies. I think what's important to keep in mind is that treatment is based on the multidisciplinary team model. Okay, so there are a number of professionals involved in the management of rheumatic disease, starting with the doctors, okay, the rheumatologist who makes the diagnosis and attempts to prescribe treatment to control disease activity, but then the rheumatologist sees the patients in clinic once every 6 months, sometimes once a year. There must be liaison with the general practitioner who will be there more available to see the patient within a shorter period of time and can help the patient with any questions that happen during the course of the patient's illness. In the hospital, there is a rheumatology specialist nurse who is key to educating the patients regarding their condition and educating them regarding the use of medications which are used to treat their conditions. We must keep in mind that a number of disease-modifying anti-rheumatic drugs are highly toxic, and if not used in the appropriate manner can cause more damage than benefit. And the nurse tries to focus on this aspect, educating the patient about the condition, how to deal with the condition, and also about the medications that the patient needs to take every day. Patients are often treated in collaboration with physiotherapists and occupational therapists depending on the condition, and also the podiatrists, particularly when involvement of the feet is problematic. Radiologists are also very important. They help us with imaging, they help us to pick up early bone marrow edema, which can be a sign of active inflammation and synovitis. And one must not forget also the psychologists. Many patients suffer from chronic pain because of their condition. This can become very depressing. There is a higher incidence of fibromyalgia in these patients compared to the background population. And the psychotherapists can be helpful to teach the patient, educate the patient, and help the patient deal with the condition.
Dr. Michaela Frendo, my very last question. What is your take-home messages for this section, for this topic? Okay,
I think very important is that early referral equates to improved outcomes. So where there is a suspicion of rheumatic disease where early treatment can be beneficial, patients should be referred as soon as possible, and judicious use of investigation so that as not to overload the rheumatology service, so that our time can be given more specifically to those patients who need early referral and treatment.
Thank you, Dr. Frendo, for your time.
Thank you, Dr.
Lu. I hope that through this e-learning video we have managed to clarify and emphasize the need for early referral for rheumatological and musculoskeletal disease through appropriate recognition of the symptoms, a clear diagnosis, non-judicious use of investigations, and obviously the appropriate use of the referral pathway. I invite you to complete this e-learning experience through the use of our attached multiple choice questionnaire. For more e-learning videos, feel free to visit thesynapse.net/CME. Thank you.
Thank you.